Umesh, can you please check with Dr. Hasmukh? Because he messaged in the group. So he should be trying to get in. Can you just check? Atharva, you are ready to present?
Yeah, so actually thing is the code we earlier created to classify CT scans into 4 different sections
Mm-hmm.
is not working really good. So I'll have to replace it with some CNN network.
Mm-hmm.
So remaining everything is done. So once I do it, I'll have code to get SUV for each organ in thorax.
Okay. So what are you presenting today?
Uh, the thing I can present is I have code ready to link CT scan and PET scans.
Yeah, please show that. Yeah. Hi, Hasmukh.
Hi, hi.
How are you doing?
I'm good.
Okay. So, Atharva, you want to share your screen?
Waiting for Lakshma to join. Or
I
is
think
it there?
Lakshman is here.
Actually,
He's here.
I'll take some
Okay,
time
Lakshman.
to open that code.
Okay.
Maybe
Okay.
some.
Yeah. We could get Lakshman to begin to present. Is it okay?
Yeah, so Dr. Lakshma is our DM medical oncologist student. He's been involved with this project right from the beginning. Uh, but so I'd asked him to review, and he has summarized the findings of what parameters can be identified from the PET-CT scan, which could
Right.
possibly have some potential like prognostic relevance. So Lakshma,
Yeah, Lakshman, can you go ahead? Yeah, Dr. Lakshman, you're there? Hello. Is there a problem, Dr. Lakshman? So, Dr. Hasmukh, just quickly updating,
I
Professor
think
Ganesh is.
sorry, Dr. Kshitij, I think he's not able to hear what we are discussing and not able to share anything. And it seems that when you look at the participants, it seems that it shows that he's on hold. So I don't know what is that.
Okay, it shows me that he's there.
It shows that he's there, but if you click on this participants link
I'm.
and then you look at the attendees, it seems that he's on hold.
Can you check now? Yeah, I don't
Just
know why is he on hold. He got on hold. Make an attendee. Okay, I've made him an attendee.
okay. So now
No idea
is it
actually.
working now?
He got to on hold right now. He was shown as guest for some time,
Okay.
and now probably he became on hold for some
Anyway,
reason.
I'll ask him to again log off and log in.
Yeah, that would be nice. Yeah.
Yeah, please do that.
So Dr. Hasmukh, just wanted to update you that Professor Ganesh is in a faculty meeting, and Venkat has some.
One second, just it is one
Yeah.
second. Sorry, please tell me.
Yeah, so Professor Ganesh is on a faculty meeting, so
Right.
he has logged in, but the might not be visible. That is one.
Okay. Oh,
And Venkat is actually has some family emergency right now. So
right.
yeah, so I'm working with him on the comments.
Yeah.
We'll
It's just only one comment
yeah,
actually.
yeah, it's just one, and actually we have discussed it. We have to just put it on paper. We have
Work, yeah,
discussed with each other. Yeah,
yeah.
so we will send it to you.
Yeah. Because we will put in that MOU and also inclusion of you as the co-investigator, etc. All of that will go in that same amendment.
Yeah, it will go together. Yeah, I understand.
So he'll take a couple of minutes. So he's going to come here only and connect from here.
Okay.
And in the meantime, you could plan your visit whenever you are comfortable, have time.
Yes.
This week, next week, you know.
Yeah. So I
guess.
was, yeah, what we'll do is we'll send you the response, and then I'll come and see to check the other features. Because first, actually, Atharva, also, could I check with you why nobody from the PET CT scan team comes on? You know, it becomes a bit difficult. Uh, like, so could you check with them, because if there are certain
Yes, I will do that, because I think what happens is typically, you know, that what we'll probably have to do moving forward is that so on the days when there'll be some days where we'll need everyone on the call, but there'll be some days where it'll be focused on either the imaging or on the pathology, and we'll have to just tell them that they come on those days, because for them also to come on a
I
weekly
understand.
basis becomes difficult. So that's one thing, of course, but that's not the only thing. Second is, of course, I can also ask Umesh to, like, in a day before, no, just inform everyone and remind them that there is a call, and tell them what is the agenda. So that way Umesh can help us in coordinating the whole thing.
Yeah, because
Those are the two
Subhash,
things.
I get on call. Subhash is my contemporary, so I just call him, and it's not a problem. But like today we are discussing about PET CT, right?
Yes.
And somebody from the PET CT,
Yes.
like Ashish, if you would have been there, it would have been really nice.
Let me also check in the meantime whether he's around.
Yeah.
Let me just call him up anyway for a minute.
Sure.
He's on another call. But
Okay.
Ashish is another call. So I think probably Umesh can help with this.
Okay.
And every, like, a day before now, if we figure this out, then probably we can kind of schedule our calls accordingly, or at least the topics we can schedule like that.
Sure.
So we could have possibly avoided a PHD related topic for today, since he's not there. But anyway, we will present whatever we from
And you're there, right? So it's okay.
I am, yeah. And from clinical perspective, whatever we feel is relevant, we will present. We will probably have a discussion again with him separately, or I'll probably have when he comes back again next time. Maybe we can redo the whole thing. That's okay.
Yeah.
I think even the students have probably found success more often when they have come here physically, rather than getting them on call. is what my impression is.
So we could come to after today's presentation, right? I could get Atharva. I could
Yeah,
get
you could have
Atharva.
some in between kind of some
Yeah.
points where you feel that it's very critical, no?
Yeah.
If this is not working out, maybe something like that we can think of.
Sure.
Anyway, so just a second.
Hasmukh, you have presentation rights, right?
Sorry, let me check that. I'm as a guest. I don't know what is the. No, I don't have the rights.
Okay, let me.
If you could, yeah, if you could do that.
I've made you presenter.
Yes.
Made you presenter.
Yes.
Ashtik, I've also made you the presenter.
Can you see the slides now?
No. Yes. Wait, just a moment. Yes, I can see your email ID.
Just 1 second.
Atharva, I would want you to take notes, okay?
Yes, sure.
Yes, this is very critical because you're going to implement this. So it's very critical that you take notes.
Is this okay?
Yes, we can see you. Yes.
Yeah, it's not in the full screen, but it's not getting downloaded. But
it's okay now.
Yeah.
Good afternoon. So good afternoon, everyone. Today we'll have a brief talk about prognostic parameters on PET-CT in case of Hodgkin's lymphoma. So here we'll be seeing the normally we have studied with pretty good evidence is SUV max, standard uptake value, and metabolic tumor volume, which is the volume of the disease that is counted at a specific SUV threshold. At each SUV threshold, the tumor volume will be measured in a scan, and all the tumor volume together constitutes the metabolic tumor volume. And the tumor lesion glycolysis is the mean tumor volume, which is multiplied by SUV mean. And the other thing is the new ones are the lesion to liver SUV max ratio and the lesion to blood pool SUV max ratio.
So blood pool is the mediastinal blood pool, right?
Yes.
Just a moment. Just a moment.
Stop.
So may I ask the metabolic tumor volume? Suppose there are five places where you identify the SUV,
Yes.
and the SUV levels are ranging from 0.8 to 5, for example, right?
Yes.
Now, if you first question is, do you do it in slices or do you do it in an vertical? How do you determine the volume is the question, basically. What do you do mathematically to determine that volume?
Okay. I think it is done in the slices.
So, sorry, Kshitij, the thing is now that these parameters are not routinely reported, and we are routinely don't do it in the clinical practice.
Okay.
Whatever we've kind of done is we've essentially looked at the papers where people have explored this. So we may probably not be the right people to give you the exact answers on how to do the calculation part.
Okay, but these, yeah. So the first three that you have mentioned, right?
Yeah,
The SUV max, the metabolic tumor volume, and the total lesion glycolysis. This is something that I had also read that is utilized. Yeah.
Right.
But okay, to mathematically calculate, maybe somebody like Ashish would be a good person to respond.
They're the people
Okay.
who will be able to help you with that.
Okay, perfect. I understand.
So the idea from our point of view was as clinicians to bring this to your notice that it will just not be just looking at the SUV max as the sole parameter. There may be something else also which we may want to explore. So that's the reason why we put this together.
May I ask another question?
Yeah.
So when you do HL grading, only SUV max is involved for the grading, right? The metabolic tumor volume and the TLG is not generally utilized, right?
Generally, it's not even so. Generally, no, we don't even look at the SUV max in terms of baseline at baseline. So at baseline, all that we are interested is what are the sites of the disease. So there are definitions of what is considered as an involved and uninvolved. For example, if you have a lymph node, if it is less than a centimeter, even if it is if there's an uptake, we consider it as not involved. So there is a criteria. So it has to be at least more than a centimeter. For example, liver involvement. So if there is diffuse uptake in the liver, or if there are focal lesions in the liver, that is considered as involved. So all that we are concerned as from a clinical perspective is what are the sites that are involved. That's the first parameter, whether it's nodal or extranodal. And the second parameter that we are concerned is what is the size of the maximum. What's the maximum size of the the largest tumor site. So because in a very crude way, bulky disease. So if you have a tumor that is more than 7 centimeters or 7 to 10 centimeter, it has some prognostic relevance. So some of the treatment protocols get little altered. So this is all that we are interested in at baseline. So we actually generally don't pay too much attention to what is the SUV max, etc.
Okay,
it doesn't really matter too much. But in the response assessment, when we do after the 2 cycles, it's at that time that this SUV max is very important, because based on that SUV, in terms of at the disease sites, what is the SUV in relation to the SUV in the liver and SUV in the mediastinal blood pool. In comparison to that, we grade the response, whether there's a response or not, or the level of response is graded according to that. So that's the only time where we actually look at what is happening to the SUV.
Yeah. So I have also read that you measure the delta change in SUV from baseline to these after 2 cycles, right?
Yes.
After 2 cycles. So suppose there is a focal lesion in the liver and the SUV is 3 after the 2 cycles. Then you go back and check what was the SUV in the first cycle.
So generally,
before the first cycle,
So generally nowadays what happens is that this delta SUV, we used to rely more earlier days, but generally now what happens is that most of the comparison happens with the other structures in the same scan. So we generally don't necessarily have to look back at the previous scan, because all our scoring, the dual scoring which is used, is based upon the mediastinal blood pool in the liver in that particular scan.
Okay, I understand.
Yeah, but we would sometimes go back and look at what is happening, in the sense that sometimes when we have a doubt whether this lesion is so if you have, suppose everything is clear but only one lesion is behind, then we may compare with the previous scan and see whether this is a new lesion or whether this is something that is so that way it helps. But in strict terms, we don't actually need even a baseline PET scan to do the response assessment. Just looking at the current scan, we make the response assessment. So that is how it helps.
Okay. And so basically response assessment is comparison to liver or mediastinal blood fluid.
Yes.
So it is never compared to the baseline.
No.
But do you think that will have prognostic significance?
In terms of what is the percentage decline, that is like the delta issue. Possible. I mean, we don't know. It could possibly be.
Right.
It could possibly be. And also I feel that some of the things that we have done is in very not in a, I mean, I don't know, in a very, very crude terms to put, is that whenever we have looked at these parameters, we have analyzed them in the way that we do as clinicians. Like we take a particular MTV and you try to find out a particular cutoff which would serve as your prognostic marker, etc. But with artificial intelligence or deep learning, perhaps there is a better way of testing their prognostic value.
Yeah, also determining the threshold, right? Yeah, because the threshold is probably arbitrarily decided.
Yes.
Yeah. Okay, continue. Sorry, Lakshman.
No. So here is a study where they have studied significance of PET-CT in the initial staging of Hodgkin's lymphoma. So how would it affect? So in this study, PET-CT was done at the baseline and the modification of therapy was done accordingly. And here the primary endpoint was taken as freedom progression, freedom from Hodgkin's lymphoma progression, which is calculated from the treatment initiation to relapse progression or last follow-up was taken as the endpoint.
Sorry. The primary endpoint was freedom from Hodgkin's lymphoma progression. So basically the second, so the second PET scan would basically say there is no progression or some progression from the previous PET scan, right?
Yes.
Okay.
No, not only that. So freedom from progression, the event is defined as patient developing any progression even at subsequent time points.
Right.
Or patient has relapsed in the future, or if the patient is disease free. If he is disease free, then he's considered at the last follow-up.
Right. Okay.
Yeah, but I think what point with this he's trying to bring out is a different point. It's not directly related to our research question, but what he's trying to bring up is that PET-CT at baseline is important because the stage of the disease can change because it being a more sensitive tool. What probably appears as a localized disease on the CT scan, when you do a PET scan, sometimes you find there's disease elsewhere also. So that way the disease can, what is historically classified as localized might actually turn out to be an advantage when you use PET-CT.
Okay.
Just as a relevance of PET-CT, but not so much for our study.
Yes. Just for that, it just showed that in 26 patients there was upstaging by using PET-CT.
Okay, I understand.
Yeah. So how bone marrow involvement was found by using PET-CT, and how did it show the difference in the median survival, means like freedom from progression, means like in 81% and in uninvolved and 93% in involved. So that way staging by PET-CT would be important.
Okay.
So here they've also studied how SUV max was divided. Well, like for few patients we had SUV max of less than 9, few had SUV max ranging from 9 to 18 and more than 18. So all of them, if you see, the 5-year freedom from progression rates was 93% when it was SUV max was less than 9, and 81% when it was ranging from 9 to 18, and more than when it is more than 18 it was 58%, suggesting that higher the SUV max the outcome is worse.
So the higher the SUV max, it is for the, so SUV max value is for the entire body, right? Like you don't do it for the entire tumor load. It's not organ specific or something like that.
No.
Yeah. So it's not organ specific.
Organ specific, yes.
Yeah. So for example, if a patient of Hodgkin's lymphoma, after the first PET scan, you find where all the tumor is, you get one SUV max value for that patient, right?
Yes. Sometimes what also happens is that it is also sometimes reported area wise. So for example, infradiaphragmatic, supradiaphragmatic, then they could, and if there are multiple nodes, suppose clustered together, then they also give an SUV max value of that particular region as well.
Okay.
So like, yeah, so if you have like upper abdominal nodes, there are multiple nodes with heterogeneous uptake. So this happens very commonly in Hodgkin's lymphoma. Then they would give that this is the thing, this is the largest size, and this is the SUV max of that region.
Okay. So region wise. So even in specific region, if it is more than 18, the freedom from progression was much lower. So that's why the higher SUV max is a good prognostic value for you.
No, it's an adverse prognostic.
It has a good prognostic value as a feature.
Yes. As a tool, it has a good prognostic.
Yeah. Okay, please go on.
But there are few disadvantages with SUV max also, because it is observer dependent. There will be changes from one person to the other.
Yeah. So actually, we have solved that problem because now we are doing it automatically. Atharva has done it.
Okay.
So we briefly to tell you what Atharva has done, he can go through these all the slices of the PET scans that you have given us, programmatically identify and calculate the SUV max, and then actually he can also now tell you which organ it is because he overlaps the PET scan image with the CT scan image. So after overlapping, he can also tell you which specific organ it is. And we have just done it for the thorax right now. So this inter-individual variability is something that we are basically trying to take care of by programmatically calculating SUV max.
Yes, but another factor here would be that sometimes factors such as what is the dose given before the PET scan of the FDG, what is the time between the FDG dose and the scan, these factors can also influence your SUV max.
Right, right.
So
Right.
but I don't think there is a way of probably solving this problem. But
Okay.
yeah, what you said is right, that at least that this problem can be solved, wherein your interpretation, at least the interpretation of the observer, in terms of what is the SUV, like two people may have their differences in terms of what they feel is the SUV max. That can be solved by these kind of programs.
Yeah. Another thing is to quickly ask you, we have standardized, if I remember, and Atharva, you can chime in. We have standardized it as per weight. So what Hasmukh you just said is that it can differ depending, each person gets a different dose, but it is standardized by weight, right?
It is standardized. I'm just saying that be small variation. Now, usually what happens in this problem we will encounter likely when we also involve other sites. Now, in one site where they have been doing this regularly, generally the things are standardized. So, what is the dose that is given? How at what time after the dose you do the scan? All those things, like the time when you acquire images, will have an impact in relation to what time the FDG was given. Now, generally, as from a clinical perspective, what happens is that you're not very stringent, but you allow for a range, saying that okay, if it is within 60 to 90 minutes after the FDG, you're okay. You will get reasonably similar kind of scans.
Yeah.
So like that. But when you're interpreting it and when you're planning to use it as a tool, there could be some differences.
Right.
This can account for small differences in the way the SUV max gets reported or SUV max happens in that particular patient.
Yeah, but if this specific site, like since we are taking information from TMH,
yes,
there will be a standard protocol
yes,
when
there is
amount of dose given and at what time after the dose is this scan done.
Yeah, so
right? So that variability is taken care of.
That is kind of taken care of. But when we get other sites, for example, Jipmer, if we get that site tomorrow, then this might come up. So this is just I'm just bringing to your notice. Not that we can do right now anything about it, but just for your information.
So right now that is also not a hindrance because it is the protocols are standardized.
Yes.
Yeah. Thank you. That is good to know. Please go on. Sorry, Lakshman.
So the next one is the total lesion glycolysis. This is calculated as a product of SUV max and maximal largest lesion diameter is taken.
So diameter in horizontal sections?
Yes.
Right, in a CT scan slice.
In a PET scan, what the imaging, what they do.
Yeah.
So the largest lesion diameter would be taken and it would be calculated with the multiplied with the SUV max, and they get the total lesion glycolysis value. And they have divided it into 3 groups, and which ranged from less than 35 to 100 and more than 100. And they have seen the how it has affected the prognosis, means like freedom from progression. They have seen that if TLG was less than 35, the FFP was 94% at 5 years and 81% in when it was ranging from 35.1 to 100. And if it is more than 100, they did it a bit poor compared to the other groups, 70% at 5 year after 5 year freedom from progression.
Yeah. So quick question here. The largest lesion diameter is again, I suppose it is automatically done, and it's not automatically done, it's manually done, right?
Yes.
You look at the radiologist looks at the site, looks at
and this through the scales that are there in the packs, they do the calculation.
Yeah. So actually, this I think Atharva, I think we should try and see if we can automate this also, right?
Yes, sure. It can
because we now are actually able to identify the total lesion. We should be able to now. There will be a scaling issue, but maybe we can discuss with Ashish what scale to utilize. Yeah.
Yes.
Okay.
So this is another study which was specifically done in elderly Hodgkins, but they have used other parameters as well. Means like SUV, as we have already discussed, this was also used. Apart from the other two, they have also used here lesion to liver SUV max ratio and liver lesion to the blood pool SUV max ratio was used. in this one, and they found it to be significantly useful. Like in this study, there are 123 patients were included in this study. I mean, it's like so they've done, and here this graph
This is
shows
survival analysis. Yeah.
yes. So
Okay.
What are the values?
so the average SUV of the lesion was 15.2 the max, which was ranging from 1.9 to 47.
Okay.
And if you see the average lesion to liver SUV ratio was 6.2, ranging from 0.8 to 21.1. And if you see the with liver lesion to blood pool, it was 8.1 ratio was there, which was ranged from 1 to 26.6.
Okay.
Here, and the tumor volume, if you see, it was 119 cubic millimeters, centimeter, and ranging from 4 to 981 centimeter cube, and average TLG was 1708. It was ranging from 9 to 8447. And univariate analysis was done on all of these parameters, and they found to be significantly correlating with the PFS. PFS is progression-free survival. So in each parameters they have seen, like lesion to blood pool, where the ratio is, they have taken ratio limit as 6.4 if it is less than 6.4 or more than or equal to 6.4.
Okay. Yeah.
And so all of them were found to be showing significant difference in the progression-free survival.
So, Dr. Hasmukh and Dr. Lakshman, so these 6 or 7 parameters that you have mentioned are, according to you, clinically relevant for determining the prognosis of the patient, right?
Yes.
Yeah. So actually, I was also going through this one paper, and I had shared it with Atharva, where actually, I don't know if you have used this tool. It's called LifeX freeware, where if you put in your data in a DICOM format, it actually gives you 47. It's something for radiomics. You get 47 different features to come up with.
Right.
So this is a growing field also, right? In your end, radiomics, where there will be some unsupervised way to identify these features to begin with. Atharva is actually reading that paper now. So, and what I'll do is I will discuss with him, and when we come to you, we will also show you if these features can be extracted or not, and are those relevant? Because again, there are too many features, and we don't want too many features because it becomes like computationally not good to have many features in a predictive algorithm. So that also we will try, and in addition to what you have just told us, maybe we'll show you a few features that can be programmatically also extracted, and you could tell us of those which are good ones to really consider.
Focus. Yes, absolutely.
Yeah, like for example, they have something like this gray level co-occurrence matrix and neighborhood gray level different matrix. All these are different. I think these are mathematical features that will be extracted based on the PET-CT image that we will be uploading. So we will also come back to you with a few. But this is really helpful what you just told us. I have been reading about MTV and TLG, but I didn't know that it would be very critical for progression per se. Okay, this is good. What I'll do is I'll ask Atharva to quickly show what he has done. Atharva, is it okay? Atharva, you're there?
Yes. I'll just share my screen.
Yeah. Dr. Hasmukh, if you could stop sharing your screen.
Yeah, I just did that.
Yeah, perfect. Thank you.
So the thing is, we were working on how to get SUV max for each organ. Right now, we are just focusing on thorax, but we can extend it to organs in abdomen. So currently our objective was to calculate SUV max for 4 organs in thorax region, which is heart, rib cage.
Atharva,
Hello.
could you share your screen because we can't see anything?
Acha. Just. Is it visible? Acha, I'm not able to share. I don't know.
I'll. You don't have rights to share?
I have rights, but I'm not able to share. Maybe I'll just rejoin in a minute.
Yeah, please do that quickly. Yeah. Are you able to share now, Atharva?
Just a minute. Is it visible?
Yes, it's coming up. Yes.
Acha. So yeah, so that was the objective, where we are planning to get SUV max for each organ in the body, starting with thorax right now. So for that we have a organ detection code where we detect specific organs in thorax like heart, lungs, vertebra, and rib cage. For that, we need to map, after we implement the organ detection code on CT scan, we need to map CT scan with the PET scan to get SUV value for each slice.
One question here, actually, Hasmukh, this question is for you guys. That in the CT scan image, we can identify we can identify the spine, we can identify the rib cage, we identify the lungs, and we identify the heart, right? What do you consider the mediastinum? Like what is the boundary for the mediastinum, or heart and around heart becomes the mediastinum?
Yeah, that so mediastinum is basically the space from the inlet, the thoracic inlet till the it actually encompasses the heart also. Technically speaking, that's a part of the superior and inferior mediastinum, and heart is actually in the middle mediastinum.
Right.
From
an imaging perspective, right?
Yeah, from an imaging perspective, I was thinking, typically we get superior mediastinal masses, so we don't get too much inferior mediastinal, but we can also get there. So from a radiology perspective, I don't know how they divide, but generally
the superior mediastinum would be before the heart starts even
above
appearing,
the heart,
right?
Yeah, above the heart.
Yeah,
yes,
above the heart. Yes. Okay, so that is good info for me. So I could, because what we had to do is I had to sit with Atharva and identify these organs manually first. And if we did 7 or 8, then he used cosine similarity to identify the organs. So, and this information I didn't have, that the mediastinal masses are mostly in the superior mediastinum.
Yeah.
So that way we can also use that information now to identify the superior mediastinal masses. Okay, Atharva, continue.
Yeah, so now we have code to link CT scan and PET scan. So these are some of the examples. So the right one is CT and left one is its corresponding PET scan. Using this, now we can correlate, like integrate the organ detection code to get SUV for each organ.
So now here, could you go back? Yeah, here, what is this PET scan telling us? It's in the lung, right?
This is in the spleen.
So it's in the abdomen. Okay.
Yeah.
So this is abdominal. Okay. Continue, Atharva.
So yeah, so these were some of the examples.
Okay. Yeah, so now he can map the PET to the CT, and he will also be able to map the organ.
Yeah.
We will need somebody from, again, radiology to sit with us a bit to delineate the organs a bit more. But Atharva and I both will come, so we should be able to do that.
Yeah.
Yeah. So this is the progress at our end.
Right.
Yeah. And now that you have told us the specific features that are very prognostically important, Atharva and I, we will sit together to see how we can reach these values programmatically, automatically.
Yeah.
Okay, great.
Okay.
This is good. Thank you very much.
Thank
Any
you.
other questions you have, Dr. Hasmukh and Dr.
No,
Lakshman?
none from me.
Okay. Great. On the other front, for the histopath images, Akshit is working,
Right.
and we have more students now on that track. So the question that about the microenvironment that was raised, that should be addressed soon. Yeah.
Sure. Yeah. Sure.
Okay.
Thanks. Bye.
Thanks a lot. Bye-bye.
Yeah. Bye.
Bye.